gotten to know each other over the last several years as we talked together about how do we collide, combine, collaborate with VHA as the clinical test bed and with her expansive knowledge in the immersive technology space and also in research design. So very honored to have her. She also, you've heard us mention several times, the Executive Roundtable. She is also a member of our Executive Roundtable. So excited to introduce you to, if you haven't gotten to meet her yet, and hear from Dr. Susan Persky.
All right, thank you so much, Anne, and thank you for being here after lunch. I realize this is sort of usually the low energy time of the day. I'm gonna try not to give into that. I promise not to dance. That's about all I promise. All right, so as Anne said, I am here to talk about refining and extending the evidence base, AKA the research, something we have sort of heard all throughout the last 2 days. Really, really important part of this journey we're all on together. So I'm happy we have this half hour or so to really dig a little deeper and give it the focus that I think it deserves. And since you're here, I'm just gonna say that you think it deserves. So a little bit more about me. As Anne said, I come from the National Institutes of Health, just up the road a few miles. And at the NIH, I direct the Immersive Simulation Program, one of the hats that I wear there. The ISP is a program that I founded in 2006, so we've been around for quite a while, and we are really a service research lab. So what that means is that we collaborate with our colleagues and help them understand how and when they may want to integrate emerging tech into their research or into their clinical practice. We do some of the work that I think this team does for the VA. We kind of hold people's hands a little bit, and we help them build things out in immersive especially, but we'll also sort of play with other tech as needed. All right. So when we're looking at the research, I think often the reason we're looking at the research in general is because we have questions we need to answer. One of the most common questions that comes up here, that comes up in my conversations, is this question of, will XR improve patient care? Okay. So this is a really big, big question, and we can think about it from sort of the highest level, right? If we think about the trees and the forest, we can kind of think about this as like maybe the atmosphere. Okay, so lots of other people have sort of thought about, considered this question. There are some really interesting reports and things people brought together on this topic that we can think about. So I really like this report out of the UK that I've put up here. This is a few years old now, but I think it's still really relevant. The NHS and the UK Research and Innovation Group put together this report on the growing value of XR in the UK. It's very UK specific. Now, I don't want to start, having any sort of like rivalry here, but I'm just saying I think this has been really useful. They talked about 3,000 plus studies evaluating efficacy of XR in healthcare, and development in the UK of over 20 clinical sectors. And now I think the slide that Caitlin showed yesterday maybe is, kind of getting up there beyond 20 clinical sectors, I don't know. But again, not a competition. We're all in this together. Something that just came out that I thought was really interesting, every year the World Economic Forum puts out a little sort of hype piece about what they are going to term the 10 top emerging techs of the year. And so in 2023, they highlighted shared immersive spaces for mental health as one of their very top 10 technology advancements of 2023. If you go into the other room there is a company that does just that. So we can actually see that in process. And that was something that I think is really exciting for this community. And then being here where I am, I would be completely remiss not to mention all of the exciting, fantastic groundbreaking work going on here, and which I think encompasses another really high-level example of what can be done and what is going on in XR and patient care. So these are kind of our high-level examples of sort of bodies of people and thought. We can also look to the scientific literature. We've seen a few of these graphs over the last couple days. This is mine that I pulled about a week ago, looking at the scientific literature for AR, VR, XR, MR, all of the terms in Web of Science. And this is published academic articles, so academic only. Over the last several years, we can see that this is on a nice rise, and we're up to 1,800 articles in a year. So really a lot going on in the academic literature. Perhaps just as important or more important is the funding landscape. And this is just data from NIH. So I should mention I'm from NIH, but I'm an intramural researcher. So I don't have money to grant to anybody, which is usually kind of a disappointing thing that people learn about me. So I'll put it out there. However, the other side of NIH, who does have the grant money, we see this massive uptick in funding for grants that involve some aspect of XR in the last couple of years. So first of all, this means that the people at NIH who really focus on research and are really into research rigor and all these things see something in XR and agree that this is something they want to invest in. And the other thing this means that there's a lot in the pipeline, that there's really good research sort of coming that's not done yet because it was just funded, but that we have some good things coming to the literature pretty soon. So exciting. So if we want to sort of ask this question and think about it at the biggest aggregate levels, will XR improve patient care? Yeah, I mean, it's looking pretty much like a slam dunk on the highest levels. But I'm a researcher, so I want precision, right? So I want more precisely to think about this question. And if we want precision, I'm going to argue that this is not actually a question we can answer. I would say that this is actually totally an unanswerable question. So why is that? Well, the first thing is that we often tend to discuss XR, sort of the technology, as if it were a treatment, right? So I'm putting a few examples up here. I think I pulled these from media. I could have pulled them from other places, but looked at some media headlines, so things like virtual reality as a treatment for ADHD, question mark. Virtual reality could treat your worst fears, right? As if take 2 virtual reality and call me in the morning, right? Obviously that's not the reality, and I argue that in general, the technology, the headset, is almost never the intervention, even though that's how we do like to talk about it. So for my purposes, I'm going to talk about XR as an enabling tool. Okay, so we think about it like a delivery mechanism. So you could think about it like the caplet. I'm not a pharmacist, but sort of the caplet around the medication that might let it out more slowly over time or somehow enhance its delivery. The two work together. Anne's giving me eyes like, okay, I did okay. All right, good. So we can kind of think about it how the two come together in a synergistic way. Because if you think about it, we really, really care about what's inside, right? So if we care about what's inside, we're going to use our XR intervention. It matters a lot. If we're talking about a 360 video where we're relaxing on a lake and we're looking at a sailboat, that's going to be really different from playing a VR game because we're distracting ourselves from something, which is going to be really different from talking to a virtual human, maybe about some health topic. Completely different experiences, all XR, but we have to treat them differently. So in our world, I would argue that content is often underappreciated. We need to focus more on it, but we also really need to think about how our content is operating synergistically with the sort of delivery of XR and how that whole package is going to work together. Now, the problem I see with trying to figure this out at sort of a large scale is that the way we're summarizing our literature, so when we go to look at how the literature on XR and efficacy has been summarized, our research is not really helping us with this. So I decided, because I have a bad habit of writing a new talk for every single occasion, to go into the literature and do a literature search, so why not? So I looked at articles from 2022 and 2023 that were either meta-analyses, so sort of statistically taking all of the studies in a given area and kind of summarizing their effect, or systematic reviews. Again, taking all of the studies in a particular area and sort of talking about what is being found. I just went for XR and pain because it's pretty low-hanging fruit. I will admit I stopped after the first 4 Google Scholar pages because already it's a lot. There's probably more. But this is kind of what I got. I got a lot of papers. Now, a lot of people did this in the pandemic. Couldn't collect research, so they did some of these summary papers, which is great, really helped us a lot. But we have tons of papers summarizing the literature in various aspects of XR and pain in the last 2 years. So I went and I looked and said, well, how are we framing our literature? If we want to think about the summary statements we're able to draw, what does that look like? So I grouped it into 3 groups. So the first 4 papers were just in the title. They're mentioning either the context or the symptom target. So I put up here an example, effects of virtual reality in maternal delivery. So maternal delivery is our context. That's where we're going to look at the effects of XR on pain. Great. We had 10 of those. We have 12, so about half of our papers where they do mention some sort of context and some sort of symptom target. So the example here is interventions for colonoscopy-induced anxiety and pain. So we have our colonoscopy context, and we have our anxiety and pain target, which is better. Only 2 studies, and I'll admit I was being really generous, 2 studies that talk anything about the content of what people are actually experiencing in XR. So I have here mindfulness for chronic pain. So mindfulness being what's actually happening in XR. And this other one, I was on the fence, but training for management. Training for management seems like content of chronic neck pain. So really, we're not doing a great job of describing our content, but that's just a title, so that's maybe not fair. So let's dig a little deeper. I selected here one article as an example. I didn't really use this one for any particular reason, except that it looked kind of good and had a nice meta-analysis figure, which I'll show you in a second. But let's look at how our summary literature tends to talk about XR. 2 things to point out on this. First, this is a meta-analysis of only randomized control trials. So here they're only really looking at the gold standard trials, or what we've considered the gold standard trials for a while, looking at exposure therapy and pain management. All right, so here's our lovely meta-analysis figure that they're showing us. For those of you who are less familiar with these kind of figures, I'll point things out. So first at the bottom here, when the diamonds are to the left of that vertical axis there, that means in a given study, VR, whatever that VR intervention is, did better than the control condition. So as we can see, everything is pretty much over to the left. So that's our first good news. And then these authors did group things into categories by the sort of context for acute and chronic pain. And that's certainly something we want to see in this literature, is making sure that that's happening as well. And that does tell us something about content, but it's sort of hidden. Okay, but where is the content? Well, let's look, because it's definitely not in that meta-analysis graph. So usually what you do is you go to the table where they describe all the studies that they looked at, and that's where you find that kind of information. You should not read this. You should not be able to read this table. Don't worry. I have taken all of the headers and put them at the top here for you. And those headers include things like the year, the sample size, the age, the stage of pain condition, the pain score measure, VR dosage, which is great and important, and we'll get to that later, equipment, and comparison intervention, and nowhere on the table is content. We have no idea what people did in these headsets, which is a little weird, but okay. So yeah, we don't have it. So what do? You go to every study individually, and you look it up. That's what I did. Not for the whole thing. I'm not that intense. I stuck to the burn dressing change category here. So what we can see, this very top box here, this is burn dressing changes, and that's our context. You can see that diamond at the bottom of that little section. That means that, in general, across all of these studies, VR did better than control. So great. So I said, okay, well, what if I wanted to do this, right? So what would I do? I would go to probably the more successful of the interventions, and I would look and see what they did. So let's look at Parker 2015. Whoa, they did Wii Sports and Wii Fit. Some people, that could be immersive, I don't know, sure. So let's look at Miller 2010. They used a multimodal handheld device with a touch and find interactive distraction story, which, okay, but it was, developed by the authors. It's not a commercial product. I couldn't go out and get it. So fine. Mott 2007 used an augmented reality device with plastic figures, creating a story. It was pretty cool. It was really neat. It was a pediatric context. Uh-oh, don't change your password. Okay. But again, not something I can get my hands on and use clinically, were I a clinician, which I'm not. And then, uh-oh, I can't click. Yeah? Okay, great. One more that I looked at. This one's the closest, I think, to what commercially we're able to get today. This was a game developed by the authors back in 2005. They based it on the game Quake, which some of you who are my age probably know what that is. And okay, so that one worked pretty well as well. But as you can see, this is not probably what we're expecting when we're looking and saying, okay, the effects of XR or VR on reduction in pain for dressing changes. We can't actually go and use any of these interventions. So what does this tell us, right, overall, knowing now what we know? The first thing this tells us is actually kind of awesome. This tells us that we have what we call in the research world conceptual replication. That means that generally, this kind of approach tends to work across settings, across samples, across time, across different kinds of content, different kinds of interventions, which is a really great thing. So it means oftentimes, but not every time, this approach is likely to be potentially successful for this use case for this symptom target, which I have to put down there because I'm a researcher and I can't not do it. What doesn't this tell us? This doesn't tell us if any given XR intervention is going to be effective in our setting for our patient, et cetera. It also doesn't tell us much about what is it about XR that's going to be successful. Like what is it we should try to amp up, or what should we really be working on here? All right, so we'll move on from my big opening and think about what we should do from here. So if we can't answer this exact question of will XR improve patient care because it's too broad, it's really unanswerable, what can we do? So first we can ask specific questions like, will this intervention be effective for this element of patient care? And then we can also ask what kind of features of interventions and what kind of features of settings are going to influence our chances of success. So this first question, will X intervention be successful? This is kind of a no-brainer. These are our research trials. This is this literature that we've been amassing for many, many years. With the caveat that our research is going to tell us when it's rigorously conducted and when the results from our research are generalizable. So those of you in the audience who are researchers are kind of like, yeah, okay, we know, but it's important for everyone else to kind of know what makes a good trial. Because this is kind of what the reality is looking like at this minute. There are more and more XR applications becoming available. We sort of saw from some of the early slides, there's a lot going on, and it's very exciting. Not a lot of it, or less of it, has been tested by a clinical trial, and even a smaller amount has been tested by a high-quality clinical trial. And there are a lot of things we could mean by that. I put a few up here. The first one is comparators, which is where we're going to go next, so I won't talk about it. But how is the trial designed? Are people blinded to condition? Does your participant know that they have the VR that's supposed to make them feel better? What kind of outcomes are we measuring? Patient-reported outcomes are super important. We also probably want to get things like medication usage or sort of downstream health outcomes. Data integrity, sampling, which we'll also get to. There's all kinds of stuff that makes a good clinical trial. Yes, comparators. That's where we're going next. Because I think this one is super important. My colleague Luana Coloca from University of Maryland and I just wrote a paper, should be out like any day now, but happy to send it. Because XR is kind of interesting and kind of special. So if we think about how we should be designing our trials and getting good rigor, we want to think about, okay, so is our XR intervention effective, but effective compared to what? So there are a few options. I'm not going to go through every little bit of this because it would be boring. But I'm going to go through three broad classes. So first thing you can do is compare your intervention to either a no control or a no treatment control. And we see this all over the literature. Very common for early stage stuff. XR is often early stage, so it makes sense. But at best, this kind of design can tell us, is our XR intervention better than nothing? And sometimes that's fine, because sometimes, for some indications, we don't usually do anything. So nothing is actually typical, and this is useful information. But that's all we could really glean from this. And so really, with some exceptions, if this is the only evidence we have for a given intervention, there is probably going to be some room for improvement. So something else that we do in this world is look at active comparators or at treatment as usual. And this tells us whether XR intervention is better than the other treatments available. And it might be a treatment we're offering people so we can be really controlled, or it might just be sending people back to their doctor and saying, just do what you would usually do. So that's what this kind of design can tell us. And I want to point out here that something I think is really important and we sometimes miss is that even if the XR treatment is not better, even if it's just as good, or sometimes even maybe not quite as good, it might still have a better profile overall, right? We may still want to try it because it's non-invasive, right? It's very low risk, so on and so forth. So it doesn't always have to come out as better. on the RCT to be worthwhile. And the last one is, I think, most familiar to people from clinical trials, and that's the placebo control. This one's a little more complicated, but basically we're saying, is the part we think is most important and active in our intervention, and this might be part of our content, this might be some of our hardware, it might be both together, is experiencing that better than experiencing the rest of what happens in our clinical trial that isn't that? Okay, and in XR right now, we are using something called the Sham VR, very popular right now, and that can take up many things, but usually it's a headset with some really impoverished version of the intervention without sort of the active elements. And that seems to be right now what people are considering to be kind of the gold standard. I will argue that not all shams are created equal. I can and did write an entire paper about this, so if you want to do Sham VR, talk to me. But I think this is a really important topic for us to think about and discuss as we move forward, for those of you who are methodology geeks and want to be in the weeds with me. All right, generalizability. This is our other big thing for rigor that I want to talk about. We do our clinical trials. Do they apply to everyone? Can we take our findings and apply them to the other people in the world that we might want to treat with this technology? Right? We are living in a country that is beset by all sorts of health disparities. I've put some disparity dimensions up here. Health outcomes differ tremendously by education, by age, income, urbanicity, which is whether you're more rural or more urban and where you live, gender, sexual orientation, race, and so on. Although we're very aware of these issues, we are not doing better, especially around race. We are doing worse. So these are data from the last several years in terms of all clinical trials. So when I say we, I don't just mean XR. I mean the clinical trial world is not doing well on inclusion. How are we doing in XR in our smaller, littler world? So I found this awesome paper. Now this is just in pain management, chronic pain management. So it's not a huge literature, but it's pretty big because this is a really active area of research. And so they went and they looked at a systematic review of all usability studies. They found 2 that included a significant percentage of racially marginalized patients. Not great. So I just point this out because this is such an important area and we can and will do better. It's really important because I love this model. It has a very researchy name, the model for intervention-generated inequality prevention, but it's super important because we started our baseline health inequity, and that is where we are. And it shows how these kinds of interventions and these kinds of advances can actually counterintuitively, perhaps, increase inequities at every stage, right? So right now we are focused, and that's why we have to engage in prevention at every stage. And right now we're talking about the efficacy stage, right? So designing our applications to be efficacious, testing them to make sure they're efficacious, making sure we include everyone in our trials. That's where we're focusing right now. And if we don't get that right, then we just kind of start this stair step to more inequity in our healthcare. So this is the one thing I'm going to say. This is my take-home message. All right, so let's shift over to features. What features of interventions and settings influence success? This is something else we really want to get from our research so we can optimize our interventions going forward. So we'll start with the features of the interventions, and this is something that Caitlin talked about earlier, about not throwing a shiny thing at every problem. This is really about figuring out when XR and what kind of XR is a helpful component. Is it a helpful component? And then figuring out what those sort of synergies are for matching features to our intervention needs, because not always going to be the same. So again, this is sort of maximizing the operation of the whole package. So everyone has their own list of features of XR that can be good and leveraged in interventions in healthcare. This is one from my paper with Luana. There's a bunch of them, not going to walk through them, because the one thing I want to point out here is that XR is it's not a thing, right? It's not a singular thing. It looks and behaves differently. These are all possibilities, and they may all be a little bit active, but they're each going to be different across different contexts. So to give an example, if we're going to talk about our distraction-based acute pain management, things like presence, so feeling like you're in that distraction environment and not in this sort of painful procedure environment, going to be really important. Multisensory might be really important if we're giving sounds that are sort of blocking out sounds around us, or smells, or all kinds of other things. Those might be really key. If we're doing a physical rehab game, presence and multisensory might be important, But we're probably going to rely more on whether things are behaviorally driven, so the fact that when we move our arm, it moves something in VR, or the closed loop system where our performance or our ability kind of moves the whole system and allows us to level up. These might be more important in this case. So that's why it's really important for us to think about and figure out how to optimize these XR features in sync with the components of the interaction content that we're using. All right, and then settings. This is an interesting one. So this is really about implementation. So what are our best practices for implementation? Because really they're going to differ all over the place, right? Across use cases and across all sorts of things. So I've put on here a few things that can be considered to be encompassed by implementation. Things like influences on adoption. What's the right dosage? Like how long should people be in VR for different kinds of applications? The settings, the environmental factors, how do we ensure safety and ethical considerations, right? These are things we've been talking about a lot here. So let's go back to our graph for a minute, because even though folks like VHA doing amazing stuff on this, when we go back to look at the scientific literature, which is where a lot of people look for this, so we see our blue line that we talked about before. That little tiny pink line at the bottom is my lit search for papers that were truly focused on implementation, and it is minuscule. So if people aren't hooked up with teams like Ann and Caitlin's team, right, where they can get that information, and they look to the literature, it's basically not there. So we need to do a lot more in implementation science in this area. We need to publish a lot more implementation science in this area. Yes, I'm looking at you. So the other thing I want to point out is that implementation science is all the rest of this. It's everything else in this stair step. It's how we prevent inequity in access and provision, inequity in uptake, and adherence, right? This is all about implementation. Super important. And then the last thing I'll say is that I think we are overlooking, and maybe less so now that Caitlin has her dashboard, right? We're overlooking all sorts of opportunities for implementation research in our natural settings. So often we're going to give somebody a medical XR application, whatever it is. We're going to look at their outcomes. This could be clinical, this could be research, but there's all these things that come in between. So we could be and should be thinking about what kind of variation we're getting in implementation and what kind of differences it make. Are some people getting it at night and some people in the morning? Are some people getting 3 hours a day and some people are getting 2? Okay, that would be too much, but you know what I mean. We should look at our context. Inpatient, outpatient, home, where are these things happening? What difference does that make? We could be looking at our mechanism, not so much implementation science, but dear to my heart, so I put it in there. We could be looking at mechanism, measuring what we think are the reasons why these applications are working. And we can be looking at something else very interesting to me, which is individual variation. So who does it work for? If we had to predict if it's going to work for this person, how might we figure that out? Well, we need data to figure that out. So I will argue that we should use every opportunity to better understand XR implementation, and we have a lot of opportunities that we're not taking right now. All right, so I will close up. So I'm going to just summarize basically the things that I said. So if we want to move this evidence base forward to meet more of the needs we have to do more in this space, we can remember that XR is an enabling tool, and we should never forget about the content. So important. We should remember and celebrate the fact that we have massive evidence for conceptual replication in the use of XR on patient outcomes across several use cases, several indications. There's a lot out there. We need more trials, we need to perform them rigorously, and we need to include everybody when we're testing these trials so that we can answer our effectiveness questions in ways that will apply to everybody. Lots more focus on implementation, and finally I would argue that VHA is really an ideal setting for addressing a lot of these needs. And with that, I will put contact information up here, and if I have time, happy to take questions as well. I stuck my Genome Institute slide in the last one. Hopefully you'll forgive me for that, but I think it'll make my institute happy, so there it is.
I think according to that clock, which I'm told to follow rigorously, we have 1 minute and 49 seconds for questions. That's about one. Anybody got a question? Oh yeah, I knew we would have some.
Hi, Adler Archer. I'm a professor and scientist at Johns Hopkins School of Medicine. And you mentioned that you don't have funding, but I wonder how you collaborate with academic institutions. So I'm very interested in creating some type of VR, XR lab at Hopkins, and we can figure out the funding piece, but the implementation science piece is really interesting, and especially technology development for health disparities.
Yeah, absolutely. And so the way we work in my program is we do have some internal funding, but often what we do is we try to create win-win situations with external collaborators, where if it's something that addresses our research needs in our institution and can address their needs, and there's a way to bring it together, we're very open to that. Please reach out, because I do a lot of collaboration, and I like to spend a lot of time trying to sort of help make XR a thing and help make it equitable. Those are kind of my two soapboxes, if you will. I have 35 seconds. I'm just saying, if anybody else. Please, someone ask me. That's okay. I mostly just like to give Anne a hard time. All right, well, thank you. And I can answer, okay. All right.
So when you were doing your literature review, were you tempted to, when you saw all the articles that have been published at certain dates, were you tempted to write a review of the reviews?
Yes, I am always tempted to write reviews of the reviews. And I think the fact that there are so many of them is really good for us, because I think it enables us to find our niche where we actually really want to focus. And I think some of these articles have too wide of a net, and that's less helpful. But I think the ones that are really helping us zero in on more specific use cases, more specific content, I think it's great that there are so many, because we're able to find kind of what we need. There are also a couple of what they call umbrella reviews, which are a review of the reviews. And the fact that our literature is big enough for that is fantastic. And I think those will be especially helpful.
But I also think your critique of what is missing in
absolutely.
those studies needs to come out too.
Yeah,
so,
I think that's fair.
So maybe not a review of the reviews, but a separate statement about what's missing.
All right, there it is. I guess I'm writing a paper.
You got one and I got one apparently.
Perfect.
So let's go.
All right.
Thank you so much.
Thank you.